Okay, I think it's time to get started. So let's get started. Today, we are presenting a webinar by the National Dental Practice-Based Research Network about periodontal adjunctive antibiotics. We are very happy that you are here today to learn more about this topic and to learn more about this study that the National Dental Practice-Based Research Network is conducted. The PAAS study will test antibiotics as adjunctive antibiotics for perio. And we have Dr. Georgios Kotsakis, a professor and assistant dean for clinical research at Rutgers School of Dental Medicine. He specialized in periodontal and peri-implantitis therapy, leading the NIH-funded Clinical Research Center at Rutgers. His interest in studying peri-implant, bone loss, and developing new implant treatments. He is the principal study investigator for the PAAS study. Joining Dr. Kotsakis is Dr. Marcelo Araujo. Marcelo Araujo, a fellow Brazilian as me, is a clinical research epidemiologist and the current dean of the School of Dental Medicine at the University of Buffalo. He has served as the Chief Science Officer of the ADA and CEO of the ADA Science Research Institute. With over 25 years of experience in various fields, his current NIH-supported research focuses on developing antibiotic prescription guidelines for dentists. And now we can hear from Dr. Araujo. Welcome, Dr. Araujo.
Good afternoon, Dr. Cunha Cruz. Thank you for having us here today. Thank you, everybody who joined us. We're very excited to talk a little bit about what we are doing in our study and also share some of the background why we're getting there. As Dr. Cunha Cruz said, I have been doing clinical research for many, many years. And as a periodontist, there are some questions there to date, we're still there to be answered, right? And one of the things that we're seeing in the last few years is some changes into prescription behavior and also the way patients are reacting to antibiotics when we prescribe them as an adjunct therapy for periodontal disease. What we understand is that there is a major concern globally towards possible resistance to antibiotic, overuse of antibiotic, etc. So what we want to make sure is so you all understand our point of view based on science of what we have to think about when prescribing antibiotic and how we validate the use, but also apply to some of the latest guidelines and classification from the American Academy of Periodontology. So our background was basically focused on the guidelines that were published on the Journal of American Dental Association by Dr. Smiley and his collaborators. It's a clinical practice guideline that look into different adjunct therapy to periodontal disease scaling and replanning. And what we see is that there was a recommendation set about different adjunct procedures, but we will focus our study specifically on antibiotic use. So we see this as a major behavior in our practice, but also we want to make sure that it's really what we should do and who are the patients that need prescribed. So as I talked to you a little bit, what we talked about some of the work that we've done. And a few years ago, I was part of a group of experts that published a paper in 2022 in JADA. And what we did was a survey, and this survey was really looking to behavior. This was not a survey to look to see if antibiotic therapy was effective to treat periodontal disease. It was a survey to look into if you are a dentist, general dentist, a specialist, or specifically a periodontist, what is the behavior you have? So what we did a survey throughout the country, and we had a very good balance of people participating in different regions on the country, just like the NPBRN. And this is why we are so happy to be partnering with NPBRN on this, because it's the next step from our research. And what we saw was that the pattern prescription of antibiotics. And you can see here, when treating patients with SRP, scaling and replanning, We saw the number of people, periodontists, and then through the ADA was general dentists, how many people are prescribing antibiotics. So SRP was a yes. So of course, as periodontists, 94% is not a surprise, the number of periodontists that do SRP. And then if you look into the pattern, periodontists are the #1 prescribers here of antibiotics at adjunction therapy. The general dentists, exemplified here by the ADA members, less than 20%. So overall, we see that 32% of practitioners in the US, they respond saying that they would use antibiotic therapy as an adjunct treatment. When we go back into the guideline, and the guideline, as you can see, and you can go back to the ADA science website and look into how they did the methodology. I'm not going to get into this. We saw that there's a lot of publications out there related to antibiotic therapy. So now we know the behavior in this country is about 34% of practitioners, they are prescribing antibiotic together with SRP. But why are they prescribing? Is that something really that we need to do? And if you look here, and if you look at these graphs, just to remember, 0 means that the odds are 0, so there's no benefit or negative impact. What you want to see is everything, what is the odds of being a positive impact? So everything that is above 0. And if you see into the different types of design, there are split groups, so people with different mouths, so that you do scaling group planning on one side, the other side you don't, or parallel group where you do both people, one group with one treatment, the other one with a control. What is most important is to look at the bottom. So what it shows here is that 0.49 of the odds for someone benefiting from antibiotic, meaning 4.9% only. So here, what we see is that 49% only. So what we see here, 49% will be benefit if you added this. So that comes to a recommendation that the use of antibiotics should be considered by the clinician when doing it. So we don't have a validation yet. So when you continue going, and I'm not going to take much time, if you go all the way to the bottom of the graphic, you see still has a positive impact of this. The odds ratio are positive, the interval is 0.2 to 0.5. So we see that there is a recommendation. So what did the panel decide? There is a moderate certainty based on science that the use of antibiotics should be used. Then what we see the benefit is small based on the science. And one of the things that you also have to think about is that was the number of patients included in each trial enough to show a difference? Okay, that's the issue that we have. You don't have large trial. That's why we are here with you today. We need a large trial to confirm. There was a lot of major adverse events, and the benefit will be small, so it's up to the clinician to decide. So the recommendation here, based on the data that exists in 2016, it's weak. So that's why this trial that we're bringing to you today is so important, because that's what we are trying, Dr. Kotsakis and I are trying to confirm and see if this is the case, or should we move to a better recommendation. With that, I'll pass to my friend, George, that's with you. And thank you so much for having me here.
Thank you. Thank you. I appreciate the introduction. And I'm taking the baton from Dr. Araujo now, who I think provide a wonderful framework of why do we need this study to conduct evidence-based periodontal treatment in our practices. And I think the reason why we titled this study Shaping the Indications for Periodontal Adjunctive Antibiotics in Dental Practice is because this is what we really intend to do. The primary aim here is to evaluate the effectiveness of adjunctive antibiotics in the treatment of periodontal disease. As you'll see in a minute, we got the most commonly used antibiotic regimen that clinicians employ in conjunction with scaling route planning, and we will assess its effectiveness in a randomized clinical trial where 36 practitioners, 36 of you from the South Central, Southwest, and Western nodes of the PBRN will recruit 16 to 22 patients with periodontitis for a total of 544 patients. Next slide, please. And this designates the regions from where we're going to be recruiting practitioners. So I would love to see all of you participating in our study. Let's please move on to the next slide. Now, in terms of the logistics of the study, patients will be compensated $50 per study visit for a total of $150 for 3 visits. And then we'll also have a $250 per participant remuneration for practitioners, for a total of $4,000 per practitioner for enrolling 16 participants. As a matter of fact, for these practitioners who are first to enroll, we will extend enrollment to 22 participants, which will end up in a remuneration of $5,500. What this really requires is you as practitioners to be willing to prescribe either our study antibiotics, which is a combination of amoxicillin and metronidazole, or corresponding placebo, and you will not know, and we will not know, once this is a blinded study, as well as complete an enrollment questionnaire and then case study forms at its visit. And our hope is that this study will really advance the science and practice of periodontists. Please move on to the next slide here. Because of antibiotic stewardship, because we're really going to be able to answer whether, one, are antibiotics really effective as adjuncts to periodontal treatment? And secondly, with some refined subgroup analysis, we're going to be able to say maybe partially yes, they are effective for these specific disease categories or for these specific types of individuals. So what will be expected of you would be to recruit approximately 16 to 22 adults with periodontitis, administer a screening form, obtain consent form, and assist the participant in completing surveys. And then we will collect the periodontal data that you collect otherwise, which would be full mouth probing depths, bleeding on probing, and gingival recession at baseline, at the reevaluation approximately 6 weeks following scaling replanning, and at the endpoint visit at 1 year follow-up. So we have 3 total visits: the baseline visit where you perform scaling replanning and you either give the antibiotics or placebo. We have the 6-week follow-up with this, the first response to scaling replanning, and then we have the 1 year endpoint visit. And at each visit, we will ask you to upload your periodontal chart, which you would otherwise be doing to assess response to periodontal treatment. The difference here in our study is that you would dispense study antibiotics or placebo to your patients in conjunction with scaling replanning, and then we expect you to do as you normally do in your practices with whatever is your practice, to counsel patients about oral hygiene, and for the purpose of our study, complete post-visit surveys at 6 weeks and 1 year. Now, what are the inclusion criteria for patients? What are we looking for? We're looking at patients that are 40 years old or older, are being treated for periodontitis stage 2 or 3, grades A to C. So this is what was previously referred to as generalized moderate to severe periodontitis. Have not used that systemic antibiotics in the previous 3 months, have not had periodontal therapy in the previous 6 months with scaling and replanning. Maintenance is okay. And then that they're willing to be randomly assigned to either a 10-day course of either placebo or study antibiotics with taking pills every 8 hours. And then they will receive your scaling replanning treatment that you would anyway do, and complete short wet-based surveys at baseline, at the 6 weeks and 1 year follow-up visit, as well as respond to on text at 10 days after baseline. Next slide. I will pass the baton now to Dr. Cunha-Cruz to take it from here. Thank you.
Thank you, Dr. Kotsakis. And as you saw, you can learn a lot more about this study by going to the our website. This is the page, and we have now time for questions and answers. If you have a question, please put your question on the Q&A box on the bottom. You can use the chat, but we would prefer that you use the Q&A. And if you are not a member of the network, you can join the network by clicking in that join button in our web. I would like to start with my first question to you, Dr. Kotsakis and Dr. Araujo, is about why do you think this study will be important to change guidelines?
Now, the studies that have been run in this area use very limited number of participants. The other thing, it doesn't take into consideration a large geographical area. So I cannot often generalize the data. So by enrolling through the NPBRN, we have the opportunity to enroll patients with different backgrounds, different behaviors from a large area in the country, different characteristics, demographic characteristics, but always is standardized to the level of inclusion that we have. By having a study that will have more than 500, we see the likelihood is that when I talk a little bit about the signs on the graphs, that we kind of try to show that we're moving that bar a little bit more. And then when the guideline is to be revised, we hope that they consider this as one of the main contributions to science. Instead of picking and choosing small studies, now we have a large, and this will be the first one done in the US at this level, study that will be able to prove the hypothesis.
Thank you, Dr. Araujo. We have another question here, and the first question is related to how will the study collect the incidence of adverse events in the study patients associated with antibiotic use?
That's a great question. We have a designated form for collecting adverse events, and we will be essentially continuously monitoring for adverse events by asking the practitioners, whenever an adverse event is reported, to liaise with their node coordinator to fill out that form, and then that will help us into providing oversight and also reporting these adverse events. And we do expect, with these antibiotics, amoxicillin and metronidazole, these are the most commonly prescribed antibiotics in clinical practice based on the survey that Dr. Araujo and colleagues performed. So we expect that we will have some common side effects, primarily including maybe abdominal discomfort or nausea as the primary areas of concern, and we'll carefully document those. Because at the end of the day, what we want to do is equip clinicians with data that truly serve clinicians, because we have this challenge, as Dr. Araujo said, of having academic studies, and sometimes small academic studies, looking at a very specific population, let's say diabetic patients, let's say postmenopausal patients, whatever the sample population of interest is. And we try to make inference from these academic studies to what the clinician does on their day-to-day activities to really improve oral health in their community. So now we have a unique opportunity to have clinicians as our collaborators to provide very, very translational clinical answers. And we're excited, and we want to know at the end of the day, what's the harm to benefit ratio for this treatment, in addition to its effectiveness based on clinical outcomes of periodontitis.
Thank you for pointing out the importance of doing this study with the National Dental Practice-Based Research Network, Dr. Kotsakis. We have a question here related to, in practice, a dental hygienist usually does the scaling and root planning. So if that happens, can they still participate in this study? And if we have more than one dental hygienist doing it, can both be part of this study in a single clinic?
So yes, the answer is absolutely yes. We do not want to deviate in any way from what happens in clinical care in the community. So if a specific practice has a hygienist that renders scaling and replanning, which is very common, we will definitely recruit that partnership of dentists and hygienists, because in the majority of states, the hygiene license does not allow the hygienist to diagnose disease. Usually it requires a dentist to diagnose disease, and then the hygienist takes over for the treatment. So whatever the process is within that practice, we will respect that, and then we will have the hygienist being designated as the person filling out the forms. And to actually fully capture that in our form, we have a question asking, is the dentist or is the hygienist filling out the form, for us to know.
Okay, that's great to know that dental hygienists can be involved in this study, because we have many in the network.
To this, one more thing is just the ability to generalize the data. So we want to make sure that the practice of dentistry does not change because you are in the study. We need you to do exactly what you do in a regular practice, so then we can make this more general.
Talking about generalized, we have a question here related to the inclusion criteria. Does it include both localized and generalized stage 2 and 3 cases, or is that not the case?
In our study, we're focusing on generalized cases, what in the past was referred to as generalized moderate to severe periodontitis. The reason is that localized disease is kind of rare. It's under 5% of study cases. And in that regard, because potentially the pathogenetic mechanism or the microbiological component that partakes in the pathogenesis of disease might be different, it would be very hard to be well-powered, disambiguate between localized and generalized. So we're limited to generalized.
Okay, and then another question here is related to the time frame for completion of the scaling and route planning. Should it be full mouse or can it be half mouse?
So I think what we have to do is, again, what do you do in your practice and what type of patient you have, right? We understand that we would prefer that if it could be done the scaling replanning at once and then you start the antibiotic, but we know that often this is not possible. So I think what it is that if you can do half mouth, but then started the antibiotic at the point where you feel comfortable that is you have to add that. George, right?
Yes, and to add to what Dr. Araujo said, the only recommendation we have for performing the study is if you perform quad SRP in 2 separate appointments, let's say at your baseline appointment, and then we call the second appointment an optional second baseline visit, we strongly recommend that it's performed within 10 days of the first appointment, and the reason is we want to have antibiotic coverage. So we give antibiotics for 10 days at baseline. So if you perform the second visit, let's say half mouth day 1 and half mouth day 7, there's still antibiotic coverage on board for that.
Talking about the course of antibiotics, I know that the study has a 10-day course, and we have a question here that considering antibiotic stewardship and generally shorter time frames could work as well, like 5 days. Why did you decide to do the 10-day course and not the 5-day course?
A lot of what we know came from the Smiley et al. Systematic review that Dr. Araujo was leading at the time, the ADSRI that was conducting the study. And we know that there's a range in the literature from 5 to 10 days. Here, because we want to make sure that we leave no stones unturned in a way, we're opting for the maximum duration of antibiotics. So when we're sure at the end of the day, they do have an effect or they don't have an effect. And then the next question would be in a subsequent study, what's the minimum duration of antibiotics that we need? But at this point, we really don't have robust data to say, yes, they help everybody, or no, they don't help anyone. So that's the kind of the $1 million question here. And
in terms of the stewardship, the issue with possible resistance showing up is that's one of the exclusion criteria are patients that have had antibiotic treatment for the previous 6 months, right? So we covered this. So there's a time frame from when they had antibiotics before, so that way we know that there's not an issue of overuse.
And then there is another question here about if you were going to control for non-systemic antibiotic treatments that may be used by the patients.
We would have to, if they are prescribed by their physicians, to use another type of antibiotic for other reasons. We need to know. We would rather they have a conversation and ask them not to do it. Topical antibiotic, if it's skin related, we don't think there is an issue. We know some people like to use to treat periodontal pockets some localized injection antibiotic. We ask that you don't do it because that's a different adjunct. So we are trying to do it, and I will go because probably that question will come later. Any other adjunct therapy that you would use for that patient during the period of time of the study, especially when they are doing the antibiotics, we ask that if you consider not using, because we really need to measure the use of antibiotic. If you add second adjunct therapy or something else, then you're going to be affecting the data because we will not be able to differentiate which one provide the benefit.
Okay, that's a good point. You are trying to see the effects, the isolated effects of antibiotics on as an adjunct for scaling and root planning and moderate to severe periodontitis patients. Why not wait for the last quadrant of scaling and root planning is completed before prescribing the antibiotic? Why is it important to have the antibiotic in the system during the procedure?
I think we base that off the literature, which says that pre-procedural antibiotics are actually ideal, because if you think about it from a biological perspective, when we perform scale and replanning, we denude the pocket of as much biofilm and calculus as we can, and also we disrupt the cellular epithelium. And as a result, when blood comes in, to provide clot stability and wound healing, it's important that this is already loaded with the antibiotics if we want to maximize their efficacy, rather than giving antibiotics later, because as we know, a biofilm can form on the root surface within 24 to 48 hours. So if we were waiting 10 days, let's say, to give the antibiotics, now we have antibiotics trying to fight a biofilm, which is much more challenging than trying to prevent early inoculation of the pocket with this gram-negative pathogenic bacteria and perio.
Thank you for your answer, Dr. Kotsakis. The other question we have here is, when will the patient know if they took placebo or the active ingredient, the antibiotic?
Yeah, we have not planned for unblinding in this study. So in our study, patients will not know whether they received antibiotics or placebo, but what they will know is that at the 1-year endpoint, based on your examination, if periodontitis was treated for them or not.
Until at least the end of the study, right? So for the next, the final examination is at 12 months. So at least they have the possibility to know after that, but not before that.
The only thing that we would unblind a specific patient will be if there is a severe adverse event, right? So major allergic issues or anything, then we would have to, because of safety issues, but we don't expect this to happen because the literature shows that this type of adjunct therapy is not harmful at that level. And the patient should describe if they have any type of allergies as they enroll into the study.
Mm-hmm.
Regular practice, right?
Yeah, well, thank you. And for the final question, I would like to know, what were the steps that you take to make it easy for the practitioner to conduct this study in their busy practice? What are the things that we do in the PBRN that makes it easier to do this study?
That's a great question, and we literally spent 1 year figuring that out in the process of launching this clinical trial, being the first interventional periodontitis trial within the dental PBRN. I will say that we have gone to extremes to make it as straightforward and least disruptive to clinicians' workflow. So what we will be doing is we will be shipping boxes, individual patient boxes, to the practitioner's clinic. And these boxes will have everything that the patient will need for our study. So in a sense, if I'm coming in as a patient, the practitioner will open that box, will find the vial with either antibiotics or placebo. It will be pre-randomized by us, and they will give it to the patient along with some forms, dental instruments, and an iPad, which will be used for filling out those forms.
One interesting thing of this study that I thought it was interesting was that the perio charts, they don't need to enter that information. It's a picture of their system, right? Can you expand on that a little bit, Dr. Kotsakis?
Yes, because data entry is very challenging in periodontitis, as you know, because we have, at least 28 teeth, and we have multiple measurements per tooth with probing depths, recession, and bleeding and probing. We wanted to make it less disruptive for clinicians. So because everybody has their own digital software where they enter periodontal data, the only thing we ask them to do is pull up that perio chart image of their software, the one they actually use to see what the burden of disease is on that patient, take a screenshot and send it to us, and we will do the data entry for them. So we're just trying to minimize any burden to the practitioner. And if I may add quickly a clarifying point that I missed before, and I see as a question, only patients who are not allergic to amoxicillin or any other antibiotics will be enrolled in the study. Patients who report history to amoxicillin will be excluded from our study.
Thank you very much for being here today, and we are very excited to launch the PAAS study. If you are interested in joining, you please do so by visiting our webpage.
Thank you everybody for joining, and hopefully this will be a study that will start soon. We just need you to join and enroll, and so we can start shipping the products for you to use and treat your patients.
And thank you to our hosts. Thank you to my collaborator, Dr. Araujo, and thank you all for taking the time to come in today. I will say that we're just very excited because this study can truly advance evidence-based dentistry in our clinics, and we look forward to having you all as our collaborators and being the hands on deck, helping us out complete that study and get answers. Thank you so much.
If you have any other questions that we didn't answer, please email nationaldpbrn@uab.edu. You can also click on the link on the chat, and there is a Become a Member page, and there is also a Contact Us page. We are very welcome to provide feedback to us about the study and about this webinar. Thank you very much, and I will see you in our next webinar. Bye, everyone.